Thank you for joining the second webinar in the APHA-NAM COVID-19 Conversation Series. This call is being recorded. Today's webinar will be part 2 in our social distancing discussion. I would like to introduce our moderator, Dr. Georges Benjamin.
Well, good evening, everyone. Hi, this is Georges Benjamin. I'm the Executive Director at the American Public Health Association, and I want to welcome you to the second webinar in our COVID-19 Conversation Series, which is brought to you jointly by the American Public Health Association and the National Academy of Medicine. The purpose of this series is to explore the state of the science on COVID-19 to inform policymakers, public health, healthcare professionals, scientists, business leaders, and the public. I'd like to thank my co-sponsor, Dr. Victor Zhao, who's the president of the National Academy of Medicine, for his support for this important effort. We're also grateful for the input of our expert and advisory group, co-chaired by Dr. Carlos Del Rio and Dr. Nikki Laurie. You can find all of our advisors listed at covid19conversations.org. Of course, if you have any questions or topics you'd like to address today or on future webinars, please enter them in the chat box or email us at apha@apha.org. Let me repeat that. If you have any questions or ideas, please enter them in the chat box or email us at apha@apha.org. Now, if you experience technical difficulties during this webinar, please enter your questions also in the chat box. Please pay attention to the chat box periodically for announcements on how to troubleshoot. This webinar will be recorded, and the recording, transcript, and slides will be available on covid19conversations.org. Now, I'd like to introduce our moderator for today's webinar, Dr. Sharon Inouye. Dr. Inouye is a member of our advisory group and a professor of medicine at the Harvard University Medical School, where she directs the Aging Brain Center at the Marcus Institute for Aging Research at the Hebrew Senior Life. Sharon, over to you to frame today's conversation.
Thank you, Georges. And I also want to thank Victor, Nikki, and Carlos. And I want to welcome all of you on the line for listening in. As you know, this is a rapidly evolving situation with COVID-19. And many more people in many more states are in social distancing or physical distancing mode since last week. So our topic is ever more relevant. Last week on our first webinar, we discussed the science supporting the effectiveness and importance of physical distancing. And on today's webinar, we're going to take it a step further to examine the risks and benefits of social distancing strategies, including the impact on particularly vulnerable populations. We'll also explore some strategies for promoting mental health during this very challenging time and discuss what science is available to guide us in terms of when and how we might eventually relax these social distancing measures. So first, I'd like to introduce our 4 outstanding speakers for today's conversation. Dr. Anne Schuchat is the Principal Deputy Director of the CDC. She has dedicated her career to public health service for over 30 years, and she's no stranger to these crisis situations. She's been at the forefront of CDC's emergency responses, including the 2009 H1N1 influenza pandemic, the 2003 SARS outbreak, and the 2001 bioterrorist anthrax attacks. We're so grateful to her as she lends her expertise and leadership to our panel and shares her thoughts on the current situation with COVID-19 nationally. Next is Dr. Jason Karlawish. He's professor of medicine, medical ethics, health policy, and neurology at the University of Pennsylvania. And one of his primary focus areas is quality of life and decision-making for people with cognitive impairment and residents of long-term care facilities, groups that are particularly vulnerable to COVID, as we know. And Dr. Karlawish will discuss the benefits and risks of social distancing measures and the disproportionate effects on certain populations. Next, we'll have Dr. Sandro Galea, the Dean of Boston University School of Public Health. He's an emergency medicine physician with expertise in epidemiology, and he's a renowned expert on the mental health impact of disasters, ranging from natural disasters like Katrina to human-made disasters like wars, mass shootings, and the 9/11 attacks. And Dr. Galea will speak with us about the mental health impacts of the COVID-19 crisis and how they might be mitigated. Finally joining us is Jennifer Nuzzo, who's a senior scholar at the Johns Hopkins Center for Health Security and associate professor at the School of Public Health, who is expert on global outbreak preparedness and response. And she will share her expert opinions on how we make decisions about potentially relaxing physical distancing, what kind of data do we need, how do we plan for different scenarios, and how do we best move forward. So this is an incredible lineup we have for you. Each speaker will provide remarks for about 10 minutes, and then we'll open up for general discussion. So to all of you on the line, we really thank you for being here. Please send in your questions and comments on the chat. We'd love to hear from you, and we'd love to try to address as many of your questions as we can during the Q&A. So now I'm going to turn this over to Dr. Schuchat to lead us through an update on the status of COVID-19. Thank you.
Well, thank you so much, Sharon, and good afternoon, everybody. I so appreciate the chance to be part of today's conversation. We are all physically apart, but we are all in this together. The COVID-19 pandemic has been difficult, complicated, challenging, and humbling. What I'd like to do in the next few minutes is really set the stage for the rich conversations that will follow. Next slide, please. The concept of social distancing, or what we're calling now being physically distant but socially connected, dates back some time. Actually, in 2007, Howard Markel and Marty Cetron, in reviewing extensive information about the 1918 pandemic and the way that different cities and geographies coped with that, coined the phrase of social distancing and really talked about those non-pharmaceutical interventions that could potentially slow the spread and reduce the peak of respiratory pandemics. As a respiratory epidemiologist and public health person, I cannot believe that how everyone in America knows about the trying to slow the spread and decrease the peak, and how expert our country has become in the science of pandemic management. But the concepts basically are including things like personal protective measures and maintaining 6 feet distance from others, and to stay home if one is ill, or now we would say stay home in general, and then community measures, whether they're related to mass gatherings, school, workplace, or as of today, I believe 270 million Americans in 33 states have been asked to stay home by the authorities in their jurisdictions. Next slide. This pandemic is hitting many areas of the world, and the United States continues to be in the acceleration phase. This map looks at the 3-day period from March 23rd to 26th, and the redder areas are the ones with the greatest acceleration of disease, with 151% or more increase in that 3-day period. Take a look at the northeast of the country, at the New York and Boston area, and then turn to the next slide, which shows the subsequent 3 days from the 26th of March through the 29th. And you can see that the red dots in that New York, Massachusetts area have shifted to more peri-urban or rural areas. So really what we're seeing is hard-hit states and then a spreading from urban to peri-urban to potentially rural areas as this virus really takes off in one community after another. Next slide. CDC modelers have looked at the potential effect of a pause where we reduce school contacts by about 80%, work contacts by about 50%, and have about a 50% reduction in other non-home contacts to estimate what kind of blunting of the peak of the pandemic and shifting to the right to slow the spread we might see with different durations of pause. So the first curve in black is a 2-week pause, and all the way over on the right you can see in yellow a 16-week pause. The purple shaded area represents the range of available bed capacity for the 10 most populous hospital referral regions in the United States, which have a combined population of 57 million. The horizontal purple dotted line represents the 2 hospital referral regions covering New York City. And you can see that New York City has pretty much the least available hospital beds on an average day of these very populous areas. And so not a surprise that New York is already experiencing the overflow and the need for alternative care sites. Next slide. I think as everyone on the call knows, one of the most visible aspects of the social distancing efforts has been school closures. And you can see that virtually all of the states have some variation of school closures. I'm told that today in Georgia we just moved from closed until May until closed for the academic year. And so this is a rapidly evolving picture. In gray, it's not no data, but it's closed until further notice, a rather ominous phrase. Next slide, please. Although it's unprecedented for us to take this kind of incredible social measures nationwide, really never seen before in the United States for this extended period, it appears that people are behaving according to the recommendations. These data show mobile phone information about the maximum distance moved by a person's phone in a particular day. And you can see this 6 states are shown here, with virtually all of them showing a dramatic decline after the first wave of school closures on March 14th, and then a continued decline once the announcement was made of that initial 15-day pause. Next slide. Another way to look at mobility is based on what's called City Mapper, where people look for the route to get somewhere, something like Google Maps and directions. And that shows that Seattle in purple began reducing their mobility based on this data source earlier, and Seattle was the first site in the country with that community spread from a long-term care facility. And then we saw subsequently drops in New York City and Washington, which were more recently hard hit. Next slide. It's been fairly, back one please. It's been fairly impressive, I think, to see the technologic and creative innovations that people have identified to enhance the ability to socially distance. But one of the low-tech approaches to social distancing seen at a carry-out venue in Atlanta was this masking tape, which measured 6 feet distance from one person in line to the next one. And we were very proud that the masking tape was officially designated the CDC social distancing limit. Next slide, please. To just wrap up setting the stage here, I want to say that this is dynamic and continually changing epidemic. CDC has developed interim resources that we update as we get more information, as we learn of new challenges and new problems, and that we're always interested in knowing how we can be serving institutions, communities, states, and partners to really help the public weather this challenging epidemic. I am really looking forward to the discussion and to hear about the downsides of this attempt to try to protect people. We know that this is an enormous social experiment, and anything we can do to minimize the negative effects while protecting health and really protecting the healthcare system to serve us all, I think will be very much worth learning. Over.
Thank you so much, Dr. Shukit, for that really enlightening presentation and the dramatic presentation in some of your graphics about the fact that people really are abiding by the physical distancing requests. So that's really heartening. I want to turn now to Dr. Jason Karlawish, who's going to present the risks of physical distancing and some of the impacts on vulnerable populations. So over to you now, Jason. Thank you.
Greetings and good evening from Philadelphia. I'm Jason Karlawish, and I'm a professor at the University of Pennsylvania and co-director of the Penn Memory Center. I'm going to be speaking about the benefit and risk analysis of social and physical distancing strategies, with a particular focus on the impact on vulnerable populations. The prior speaker, Dr. Ann Sushat, spoke much about the benefits. Much of my talk is now going to focus on the risks. I want to thank the National Academy of Medicine and the American Public Health Association for organizing this, and Dr. Inouye for chairing. The outline of my remarks will begin with explaining the concept of being vulnerable. Next, I'll take a closer look at who is vulnerable as a result of physical distancing. I'll then introduce a framework to address this vulnerability during a pandemic, and close with some preliminary thoughts and recommendations. What do we mean when we say vulnerable? The definition I'll offer is being relatively or absolutely unable to protect or advance one's rights, interests, or well-being. When we think about physical distancing, the question I then have when I take that definition is, well, who's made vulnerable by the act of physical distancing in a pandemic? And I'd like to submit that there are at least three categories of people. First, people who need physical closeness in order to survive. That is to say, they need care. Second, people who provide services that require physical closeness. For example, people who are caregivers. And third, people who provide services that facilitate physical closeness. I'd like to submit as a point of principle that sometimes physical distancing causes social isolation. Think, for example, of one of the ultimate punishments in our penal system, short of execution, that is solitary confinement. So let's take a closer look at who's vulnerable. So in this table, I have organized it into three columns. The headers are the three categories I introduced earlier. And I'd like to kind of walk through particular examples within each of those categories. Going from left to right, we'll start with those who need physical contact in order to survive. So, for example, those are individuals who are living with a disability, either an impairment in their ability to perform an instrumental activity of daily living, like managing their money, or cooking, or driving, or a physical activity of daily living, particularly bathing, dressing, grooming, and toileting, the ADLs. And within this, obviously, are categories of people divided by whether they have a physical impairment or a cognitive impairment, or, of course, both. Within the category of cognitive impairment, we think of individuals who have either mild cognitive impairment or dementia. Another group in this category are persons who need chronic or intense face-to-face hands-on care. Individuals, for example, who require dialysis, chemotherapy, or who are enrolled in hospice. There are persons who need acute medical care. They're in a hospital. Persons who live in what's called a total institution. A total institution is a term that describes a place where people not only live but work and recreate. Examples of a total institution are college students who live on a campus, prisoners, or residents of long-term care facilities. And finally, in this category, I've thought about persons who don't lack access to the internet, something I think all of us right now realize, while we're physically distant, are not socially distant. In that middle group now, I want to talk about people who provide services that require social or physical closeness. And this is not a complete list, but it's intended to get you to think about, for example, caregivers, people who either informally, that is to say, family members, for example, or formally, that is to say, they're paid to assist someone to perform instrumental or basic activities of daily living. We can think about people whose employment is to run and otherwise work at an adult day activity program or a child care program, or who do domestic work or cleaning, who are in the food service industry or entertainment. The point being people whose job is to provide services that require face-to-face engagement with other people. And finally, that third category are kind of those who supply or facilitate work that leads to physical closeness. So, for example, a food supplier to a restaurant or to an adult activity program. I'm thinking of people whose jobs are to support people who provide services, such as for an adult day program. All of these I'm going to maintain are in some way made vulnerable by a social policy of social distancing. Let's take another closer look at the vulnerable, recognizing clearly that people can have multiple causes of vulnerability. For example, a person who has dementia, who requires dialysis, lives in a nursing home, and enjoys walking about that home and visits from family. I hope that you appreciate that that individual faces multiple possible routes of exposing and spreading COVID, going to dialysis, walking about the facility, being visited by family and others. A strategy of physical isolation into the room of that resident's room is now going to cause social isolation, and in that room alone, without visits from family, this individual is at risk of delirium and decline. Another example that mixes causes of vulnerability is a certified nursing assistant at that same nursing home who needs to take public transportation to the facility and has multiple children at home. Again, multiple possible routes of COVID exposure as well as spreading it. A job, though, that is essential for others' survival. The survival of the gentleman I described above who has dementia, but also the survival of her children who require her, his children, who require the CNA to work and bring home a paycheck, putting others at risk. Here's a recent blog post from the London Review of Books by the Nigerian writer, Adwala Maja-Pierce, who describes how telling the majority of poor to stay indoors in Nigeria is impossible. The point about a developing country is that the majority of poor depend on their daily wages to feed their families. It's hunger here that people fear, he writes, not a virus they can't even see. They need to get out on a daily basis to make money to feed themselves and their families. Social isolation just simply is impossible for them. Back in America, this map illustrates another example of combined vulnerability. This map depicts, state by state, the uninsurance rate for food service and preparation workers in 2017. The point of this is they're in a job that requires getting out and potentially interacting with other people, such as waitering and other things. They don't have insurance. So if their job is ceased because of closures of restaurants and other types of food service facilities, they don't have health insurance because they are uninsured. Next, I'd like to introduce a basic principle of justice that helps us think through this vulnerability in the time of a pandemic. The basic principle of justice is that we need to treat equal people equally and unequal people unequally. Persons who are vulnerable are unequal to persons who are not vulnerable. Therefore, someone who's vulnerable merits or deserves more and to be treated differently than people who aren't vulnerable. So in a pandemic that is being treated by physical distancing, the question we have to ask is, how are people equal or unequal with respect to what? What should matter when we decide you should be treated differently? And I've put down here at least 5 things that need to be considered. One is having health insurance that's tied to employment, because if you lose your job, you lose your access to health care. Living in a private space allows you to be obviously distant. Working at a job that can be done remotely. having easy and regular access to technologies that close social distance, that is to say the internet that we're all enjoying, and being able to perform one's own activities of daily living. In a pandemic, I would submit, survival supersedes quality of life, rights, and interests. For example, demanding free assembly in public spaces, such as to have a demonstration or some sort of rally, is simply not important, and it's not going to happen. And finally, another principle here is that in general, we want to live days that are safe, social, and engaged. And of course, this is a balance, a kind of triangle. You can't have a day that's fully safe, entirely social, and totally engaged. And we have to achieve a balance. Right now, in this pandemic, obviously that balance is tilted quite towards that vertex, if you will, of safety. Okay, let's start putting things together. So think about how applying physical distancing would affect these three very different kinds of people. First, a very wealthy person who has paraplegia. Second, a person with dementia who requires dialysis and lives in a nursing home. We talked about that individual. And third, that's CNA I talked about. And what I've done here is gone through those various criteria that we should think about when we think about justice with respect to the vulnerable in the time of a pandemic. Let's go down the list there. Our very wealthy person who has paraplegia, well, she or he has health insurance, lives in a private space that's an accessible residence because it's been fitted to allow getting in and out, certainly can work at a job remotely, courtesy of the internet, etc. Has easy access to the internet that allow close social engagement, and finally is able to hire whatever help is needed and even have them stay there with him or her to do IADLs and ADLs. Our resident of the nursing home has health insurance because we'll say he's over 65 and therefore has Medicare. But in that setting of the nursing home, there are group meal settings. It's simply impossible to serve meals individually in rooms given staffing issues. Maybe even has a roommate and has to go to the dialysis center 3 days a week. Having easy access to technology simply isn't available to this person, both because of cognitive problems, but also of the lack of ready access to technologies that allow remote connection in many nursing homes. And finally, needs someone to help him or her do his IADLs and BADLs. That's CNA, now in our third column, who has health insurance, yes, but if loses job, maybe doesn't have health insurance because it's tied to employment. Lives with others at home, needs to travel to his or her job, and has to work in this other setting with other people, doesn't have the ability to do the work of the CNA remotely, and finally, though is able to perform IADLs, etc. So I hope you can see the spectrum of how these people are unequal and therefore need to be treated differently. So, back to that table I showed you earlier, I bolded this particular group and I'm putting the cursor over it. I think that one of the, going forward, we need to think very closely about persons living in total institutions. Our earlier presenter showed us how colleges are solving this quite easily by simply shutting things down, and schools. But prisoners and residents of long-term care facilities need extra and additional thought. And so with that in mind, what I'd like to do is offer some preliminary thoughts and recommendations to address these, sources of vulnerability. Well, first, where possible, we should try to remove them. So, for example, I listed out a host of different kind of workers who depend on physical closeness to do their jobs. Many of these people will, if not already, are unemployed, and as we know, there's been an enormous spike in the unemployment filing. Simply, this is a clear opportunity of social policy to address that loss of income. They need access to health insurance. It would be very interesting now to think about further political discussions about modifications to access to the Affordable Care Act. Schools, of course, are being closed. We should think about broadening our ability to give people access to the internet across every bit of the country. And finally, ponder things like prisoner release or parole. But even after addressing these sources of vulnerability, and that my list is not complete, some people, of course, will still remain vulnerable. And I would submit that the more a person is vulnerable, the further up in the front of the line they are for personal protective equipment, testing once it's widely available, treatment should they ever be available, and a vaccine. So that's a principle of access and who has what place in the queue in line. Finally, I would say that we must pay attention to total institutions such as nursing homes and prison. I can tell, as we know from Seattle and in my own city, they are ground zero for our attention because they are ground zero for this epidemic, this pandemic, and it's going to be that case for months. And so we need to think about, for example, how Medicaid funding can be a pipeline to most nursing homes and Medicare to dialysis in order to get them the resources they need, such as access to personal protective equipment. Many nursing homes are sorely under-resourced for the essential PPE that they need. We need to crowdsource ideas to improve access to PPE, as well as to create safe social and physical connection in these congregate living settings. For example, family could be trained to be CNAs. There could be allowed to have selected or escorted visits to see their relatives. We could use technology to allow better connection remotely. In-hallway dining. I realize some of these things are very peculiar and particular, but nothing at this stage and this time right now is too stupid or outside the box. I'd like to close with this observation. With this COVID pandemic, we're faced with a disease that is incurable and it is untreatable. We sadly have to almost let nature take its course, of course, providing palliative care. And so we are right back to where we were before modern medicine, in some sense. We have to take caregiving seriously. Caregivers, humans, are really like the influenza vaccine, the vaccine we desire for COVID. They're like penicillin. But social distancing can clearly impede the ability to deliver care. And this is our national dilemma that we have to address. Thank you.
Well, thank you, Jason, for that insightful analysis. And clearly the risks are very serious and the solutions are going to be difficult. But we need to carefully balance those risks against the tremendous mortality risk of not doing the physical distancing adequately or long enough. And so I see that questions are pouring in, and so I want to move on so we have time to address them. So I'd now like to turn this over to Dr. Sandro Galea to take us the next step and probe further about the potential mental health risks of social distancing and potential mitigating factors. So thank you, Sandro. Turning over to you now.
Well, very good. Thank you for having me. Thank you, National Academies, and thank you to American Public Health Association for arranging this. So in my 10 minutes, I want to talk about mental health and COVID. And I ground my reflections in the observation that what's going on right now is a trauma. It is a global trauma, and focusing on the U.S., it's a national trauma. This is a definition of a traumatic event that I have used for decades, really. A lot of my work, I've studied trauma and mental health, and this is a traumatic event is an experience that causes physical, emotional, psychological distress or harm. It is an event that's perceived and experienced as a threat to one's safety or the stability of one's world. This definition typically has been applied to more typical mass traumatic events like terrorist attacks or hurricanes or floods. But I think anybody can see that it applies equally well to what's going on right now with COVID-19, both the pandemic itself as well as the efforts to mitigate the pandemic. So when we understand this, I think we can ground a fair bit of our understanding in the literature on mass traumatic events. So I thought I would make 7 points. I'm going to make 7 points with just one data slide for each, and I'll go through each one of them. Let me start this way. Number one is the prior evidence from a whole range of studies that has accumulated largely over the past quarter century suggests that there is an increase in mental illness after traumatic events, after mass traumatic events. Much of that is in the mood anxiety disorder spectrum, and that means things like depression, anxiety, post-traumatic stress disorder, increased use of substances, alcohol, cigarette use, cannabis, as well as increase in behavioral disorders, things like domestic violence. I just have one slide to show you on this. This is after from work my research team had done after the 9/11 attacks in New York City. And what you see here is a density map of the density of post-traumatic stress radiating out from where the World Trade Center was, which, as you will remember, was at the south end of the tip of Manhattan. And what I want to show you here is these sort of concentric circles with lower prevalence as you go further out from 9/11. And that was, I think, a consistent finding across many studies. The closer you are to the trauma, the higher the density of the mental illness. Now, of course, this is a trauma that is global and national. It's not exactly clear to me at all where the epicenter is, and it's something that spreads across the country. But the bottom line is that the previous evidence suggests that after traumatic events, you're going to have an increased incidence and severity of mental illness. So that's point one. Point two is that the emerging evidence after COVID-19 is that that's exactly what's beginning to happen after COVID-19. Now, we're still early in the epidemic, but there are actually a few papers that have been published in literature, most of them from Asia. And I just want to just show you a couple of them. This is from one of them, which actually looked at the prevalence of anxiety, depression, and PTSD symptoms. And what I want you to see is the prevalence of people. So the blue bars are anxiety and depression, the red bars are PTSD, and the bars on the right are comorbidity, which any symptom of anxiety, depression. Red is any symptom of PTSD, and the purple is both anxiety, depression, and PTSD, at least one symptom. You have about 50% of people in this one study had at least one symptom of anxiety, depression, and PTSD. And when you look at PTSD symptoms, you had 15% of people had 6 PTSD symptoms. That's in the red. The study wasn't designed to come up with diagnostic PTSD or anxiety or depression, but I think it gives us a clear indication early on that these symptoms are emerging. The second other study, which actually you can see here, uses the PHQ, which is a validated diagnostic instrument for depression. It also looks at anxiety, insomnia, and other symptoms of distress. But I highlighted in red the top right of this busy table, but I kept the table as it is, given this is a science audience. And all I want to draw your attention to, and I hope you can all see the table, is there are columns here. The left, if you just look inside my red circle, is Wuhan in China. The second column beside it is Hubei province outside of Wuhan, and the third column is outside of Hubei province. So that means you are actually getting to closer and closer to where there was more COVID-19. And if you just focus on PHQ depression, the rows are normal, mild, moderate, severe. And all I want you to see is that in the Wuhan column, you have more people who are severe and moderate, more severe than there are in Hubei outside of Wuhan, more moderate than there were in Hubei outside of Wuhan. But then when you get to normal, you have more normal in Hubei outside of Wuhan. So in other words, the early evidence, again, these are really early studies, are that the closer that residents were to Wuhan, which was of course the first place of diagnosis of COVID-19, the higher the likelihood of severe symptoms of depression, which, if you think about it, is exactly the same as what I showed you about PTSD after 9/11. And then one other slide from a different study that came out. This looked at variables associated with, in this case, depression. And these are multiple variables on the left. It's a fairly typical graph, but all I want you to look at here is the bottom row. And the bottom row looks at social media exposure. And you see that social media exposure frequently is associated with greater likelihood of depression, and sometimes a little bit less, both of which are much more than less social media exposure. This, again, is consistent with what we saw after, what we've seen after terrorist attacks and disasters in the past 20 years. So this event is certainly beginning to behave like we have seen in the past 2 decades in studies of disasters and mass traumas, which suggests that we are going to see a fairly predictable pattern of depression, PTSD throughout the country and the world. What is different about this event, of course, is the enormous geographic scope that it hits. Now, moving on to the third point. The third point is that right now I've just talked about the mental health consequences of the COVID itself. We also have an economic downturn that is compounding the influence of the COVID, as you heard, and there are going to be ongoing stressors that are going to compound mental health as a result of the economic downturn. This is simply just a graph to remind us of what's been going on with the economy. And I could spend an hour talking about the literature, about the mental health linked to economic downturns. This is just a very simple graph looking at economic indicators and likelihood of suicide. So on the x-axis here, you have index of economic indicators, and on the y-axis, you have the rate of suicide deaths in New York City. And as the economic indicators get better on the x-axis, you see suicide rates go down. And this is pretty consistent across a range of literature. And I could show you economic indicators linked with a broad range of common mood anxiety disorders. I'm just showing suicide to make one point. So the economic conditions will themselves have their mental health consequences. Now the fourth point is that a key part of this picture is not just that the economic consequences are one time. They're not just punctate. They're not just punctate events. What they are ongoing stressors. And one of the pictures that is forgotten after disasters typically is that we tend to think of disasters as something that just happens. They happen and then they're over. But when you look carefully at the science on this, what really matters to mental health is the stressors that go on in the long term after a disaster. And those stressors themselves influence the incidence and the trajectory of other mental illnesses. And to make that point, I'm just going to show you one data graph. This is a graph of people with post-traumatic stress disorder after Hurricane Katrina. So this is a survival curve. Everybody on the left of the y-axis essentially had PTSD. And as you go forward in time, you see we're going over a couple of years here, you have people have remission of PTSD, either natural remission or else through treatment. But what you see here is there are two lines. The PTSD curve splits. And there are two curves, one labeled high stressors, one labeled low stressors. And that the people who experienced other stressors, and here in the study, other stressors were things like having a hard time paying the mortgage, having a difficult time with putting children in school, being worried about one's parents, which you'll all recognize are things that are going on right now. Those who had those stressors were likelier to have PTSD for longer. So essentially, ongoing life stressors are what drives the trajectory of mental illness after the initial insult happens. Fifth point, we're talking about mental health, and I was asked to speak about mental health, which I'm glad to do, but I do want to make the point that mental health is inseparable from physical health. When I talk about mental health, if you believe the argument I'm making, and if you are a reader of the literature that I'm reading that shows exactly what I'm suggesting is going to happen, you'll then also realize that this mental health burden is going to be also a burden that's going to accentuate the physical health burden after this event. And let me show you just one graph to make this point. This is from a study that our group had done. This is what you see is people age on the x-axis. But what really matters here is cumulative incidence of type 2 diabetes. If you look at the black line, which is the bottom line, these are people who never had traumatic events. And what you see is as you get older, your incidence of diabetes goes up with age. Nothing surprising there. But what I want you to see is that the slope of that line gets steeper and steeper the more traumatic symptoms people, the more traumas and traumatic symptoms that people have experienced until you get to the, I guess it's the pink line, which is the steepest. Those are people who have experienced trauma and who have had symptoms of post-traumatic stress disorder. So the natural incidence of diabetes, which goes up with age, that slope gets substantially steeper if you've experienced the trauma and you've had PTSD symptoms. That means that the mental health burden after COVID and after the consequences of COVID that I am describing we should expect to happen is going to influence the burden of physical disorders after COVID. So that's one way in which mental health is linked to physical health. And then I want to show a totally different slide just to make this point, because I feel like this point has not been made in the public conversation. And what this is the data from perhaps the most comparable recent incidents on this. Probably the two most comparable recent incidences on this are SARS and Ebola. This is a slide about Ebola. And what the slide shows, if you just focus on the bottom right, you can actually focus on any of these charts, but focus on the bottom right. The green lines, which you see going up and down, are the Ebola epidemic. The bars are not Ebola at all. The bars are actually malaria. They're the diagnosis of malaria and deaths from malaria. So what's actually interesting about this, if you just look at the bottom right, is that Ebola cases went up, malaria cases also went up, but then after Ebola was resolved, malaria cases still went up and deaths from malaria went up. And the reason I'm making this case is that what happens after these events is that not just the mental health consequences, but the physical health consequences get worse simply because our health systems are all focused on dealing with one specific subset of disorders, which is namely the epidemic, leaving open the whole ground for other physical conditions. Sixth point, the mental health consequences, unfortunately, are long-term and lasting. I think right now our attention is all diverted on the urgency of COVID, and it is appropriate. COVID is a terrifying disease, and it's going to result in more than 100,000 deaths in the U.S. alone, which are deaths which we previously were not counting on. It is also important to remember that So by the grace of God, unless something changes, we will get through COVID. But the consequences, particularly mental health consequences, are long-term, and they're going to be lasting for months and years after we're over the acute part of the COVID epidemic. And just to make that case, I just want to show you some data from a study we had done in Africa. And all I want you to see here is this is from a province in Liberia. And the dots here are areas where there was conflict. And that conflict was 25 years ago. 25 years later, we did a study, and the dark dots are areas where there was high prevalence of PTSD. And really, all I want you to see is that 25 years after an area where there was conflict, you could trace the path of trauma by looking at the burden of post-traumatic stress disorder in this one region in Africa. 25 years later, really a quarter of a century later. So the echoes of these events goes on for a long time, and the reason for it is not just the initial trauma, but also the initial trauma compounded by the stressors and compounded by the social and economic upheaval, which is exactly what we are seeing after COVID. So my last point, having said all that, we can mitigate some of these consequences. How do we mitigate some of these consequences? Obviously, we could spend an hour talking about mitigation, but just 4 points: education, surveillance, step care approaches, and improving conditions. So very briefly, one of the challenges that we have is that as a society, we remain really, really far behind in educating the public about mental health, destigmatizing mental health, making sure that people come see providers in a timely way about mental health, and also normalizing normal symptoms. A normal anxiety adjustment reaction, normal sadness about being locked in your house is normal. It's not necessarily pathological. But we do not have that level of education that then allows us to screen people, screen the normal reaction from the pathological. Number 2, surveillance. Part of that is surveillance, actually being able to monitor mental health symptoms, be able to monitor the emergence of mental illness. Number 3, stepped care approaches. Stepped care approaches means creating a system where we educate, we monitor, and refer to treatment only the people who need it. And there is a good growing literature that stepped care is the right way to deal with large-scale traumatic events. And number 4, improving social and economic conditions, which hopefully should now be clear why I'm saying that, given how much social and economic conditions compound mental illness after traumatic events. And this slide, which I want to show you here, is from a modeling study that we did. And what you see here is, you can look at any of these, but just focus on the bottom right, just for the sake of focusing on that, is you have the red line is stepped care approaches, and the purple line are usual care without improving social and economic conditions. What we did is here, you can model the survival curve, the progression of mental illness. And what you see is that the steepest decline, the most rapid resolution of mental illness is the red line. The red line is the line where we're implementing stepped care approaches coupled with improving social and economic conditions, which were my points 3 and 4 in the intervention. So coming back to 7 points, the evidence does suggest we're going to have a substantial decrease in mental illness. The emerging evidence is consistent with that. This is going to be compounded by economic downturn and long-term ongoing stressors. These mental health consequences will also compound physical health. They will last for a long time. We can mitigate some of these, but ultimately, this is the next wave of the consequences of this pandemic that we have a responsibility to be prepared to deal with. Thank you for having me.
Thank you, Dr. Galea, for that really informative talk and so much for us to think about together. Now I'd like to turn to Dr. Jennifer Nuzzo to help us understand the decision-making process about when to and how to end the physical distancing. How will we know when to stop, and what will be the next steps? So over to you, Jennifer. Thank you. Jennifer, can't hear you.
Sorry. Hi there. Thank you so much. I really appreciate the introduction and being able to speak to this topic. Life has changed clearly a lot in much of the world, and certainly here in the United States within the last few weeks, I think we are living in a situation that is largely unprecedented. Trying to advance slides here. Okay. Though we've known about COVID-19 for months now, and we've been seeing very worrisome impacts in many countries across the globe, I think perhaps one of the more stunning developments as of late was the rapid rise in cases and reports of serious illness and death in Italy. A Lancet paper that was published in March described some of the early hospitalizations and admissions to intensive care units and raised the possibility that the country was possibly weeks away from exceeding healthcare capacity. Here in the United States, I think that this was a bit of a galvanizing report. Data and images of overwhelmed hospitals, was a bit of a reality check, and really I think caused many to ask whether we would see cases similarly rise in the United States and if our health systems could keep up. And I know many people at this point began to worry in particular if the U.S. was possibly on the same pathway and if we were weeks away, weeks behind, only just weeks behind Italy and experiencing some of the same levels of health system stress that they were seeing. Fortunately, and possibly relatively at this point, I think is when state governments really began to implement social distancing in an attempt to slow the growth in the number of COVID-19 cases and in hopes of preventing health systems from being overwhelmed. Of course, we're still hearing of these stories of stress because these measures that we're implementing, take some time to show an effect. And so, though there may be some glimmers of hope in some places in terms of a potential flattening of the curve, it still takes some time to see that. But I think at this point, many states have begun to implement measures. And although the measures taken in each state differs, I think the trend overall is that increasingly states are implementing stronger and stronger restrictions. And so this, ranges from closing mass gatherings, closing schools, and then even in some places to shelter-in-place recommendations. So that's where we find ourselves. We're largely at home, limiting our interactions, not showing up to work if we don't have to, trying to do it at home as much as possible. Clearly, there are parts of our society that need to still function, but for the most part, in many places, life has changed considerably, and we're hoping to do our part to slow the spread. The question that probably everybody gets asked who weighs in on these issues the most is how long will this all last? How long do we have to maintain these measures? We know that these measures aren't a cure. They're not going to stop the virus from circulating, and they're probably more equivalent to hitting a pause button on the rapid acceleration of cases. We also know that if we let up on these measures, we can expect to see a rise in cases once again. But at the same time, for reasons that the previous speakers just illustrated, we can't maintain this level of shutdown forever. There are certainly harms associated with the measures themselves. So we need to figure out a way to be able to return to normal and how to do that safely. But figuring out when we can safely begin to ease up on these measures, and it will be more of a question of easing up and not just lifting measures entirely, we need to also think about then what comes next and what we will do to respond in the rise of cases that's going to occur. So that we don't find ourselves back to where we started. We need to figure out what the work in the next phase will be so that we can, suppress the cases that are emerging so that we don't once again see accelerated growth. So again, social distancing is a tool, but not a solution to the pandemic. What I'm showing here is from Imperial College of London. They did a modeling looking at various different modeling strategies, different social distancing strategies, and what their likely impacts would be. And there are a number of takeaways from this, and although I have points to quibble with here and there about these models, I think it just illustrates what the reality of the situation, which is that these measures will have to be maintained, and if they are lifted entirely, we will see a rise in cases. And in this particular study, they looked at it over an 18-month period, likely because 18 months is one of the early estimates of when we could potentially have some vaccine, although that may even be an optimistic estimate. So there needs to be a next phase of action. We can't just I personally think it's unlikely that we can maintain this level, the current level of social distancing for 18 months. But if we are to do something different than what we are doing now, we need to have a plan B. And so what will that plan be? What is that next phase of action? What measures can we take then to limit the spread of COVID-19 such that we don't find ourselves worrying once again, will our health systems be overwhelmed? And I think there are some potential models out there that we can look to. One really promising, I think, approach is Singapore's experience. It's interesting, Singapore didn't really implement any of the social distancing measures that other countries in Asia did, not fully. What they did was they relied on sort of tried and true public health measures. So aggressive case finding, case isolation, contact tracing, and monitoring. They found their cases early, and then they conducted detailed epidemiologic investigations in an attempt to find anyone who may have been exposed to an infected person and monitor those individuals to ensure that if they became a case themselves, they wouldn't further transmit the virus. And they were largely successful. I mean, they were able to reduce their incidence through these very targeted case-based measures. But these measures, you know, as much as they're probably going to be a backbone of our next phase, are very laborious. And if we are to try this in the United States, which I believe we will have to, we are going to need additional resources and tools to enable this kind of approach. You know, this kind of, just the contact investigations alone, you know, likely, I mean, certainly with case numbers where they are right now, it's definitely out of reach of almost essentially every health department in the U.S. But perhaps once we get the case numbers lower, it can be attempted. But even still, there are very limited resources to conduct these sorts of investigations now, and clearly additional resources in the form of new technologies and new personnel, you know, volunteers likely, will have to be brought into this. Another potential model is South Korea. I think probably by this point everybody's heard about the success that South Korea had in flattening their curve and reducing their case incidence. It's pretty famous for how it rapidly expanded testing for COVID-19, which enabled it to find many more cases in the community as compared with other countries that are largely testing people in hospital settings. And so by testing the broader community, it enabled them to identify and isolate cases early, possibly, you know, milder cases that may otherwise not have been caught had they not done this. And then through a very, very aggressive technology-supported contact investigations, they could then monitor and test exposed individuals and hopefully kind of limit transmission by isolating them if they are found to be infected so that they wouldn't pass on the virus to others. So, you know, I think what these examples show us is that the next phase for us will likely have to rely heavily on these tried and true sort of public health measures, the case finding and isolation, contact tracing, contact monitoring, and then ultimately isolation if they become cases. You know, this test, isolate, repeat phrase that people have been stressing, particularly the WHO. I think this is very much in our future. But when we get to that next phase is a question, right? So what does this mean for the United States? When are we able to move to this next phase? If we want to be able to ease social distancing, we have to have confidence that the number of new infections that are occurring won't outpace our health care capacity. And in order to know this, we need to conduct surveillance in two main areas. The first one is that we need to better understand the occurrence of disease in our communities. And that sounds obvious. But while individual states are publishing total case counts alone are not enough to help us gauge if the situation is getting better enough to release social distancing measures. We need other data to help us interpret case increases or decreases. We need a way to track, and ideally in one place and not on 50 different states' websites, what criteria states are using to test people, what percentage of states' populations have been tested, and what proportion of tests are positive. The case numbers alone can be very subject to changes in surveillance, and so it's really hard to interpret increases and decreases without understanding what kind of surveillance they're doing. It's also really hard to compare case numbers between states if, first of all, we don't standardize that by the population and also understand how different states may be approaching testing in the first place. Once we see that case numbers are falling despite increasing numbers of people being tested, we may begin to be reassured that the social distancing measures are having an impact and that we can begin a phased return to normal life. But we won't know that until we have more data. And I think people are working hard at trying to improve the availability of these data, but it's really, I think, going to be an area where we need urgent action. And then the second type of surveillance we need to be doing is to better monitor the strain on the health system. So what we're trying to gauge really is if we've flattened the curve enough beneath the line, and the line represents what the health system is capable of doing. But in order to understand if the health system is okay and not at risk of being overwhelmed, we need to understand what level of strain it's experiencing. So there are some ways that we potentially can collect and analyze these data. I mean, one thing is that we don't regularly report what percentage of cases are being hospitalized. Some states do, but not all do. We should probably also understand how many of these hospitalized cases are requiring intensive care, because that's probably one of the most limited hospital-based resources that we have. And then we need to know if the hospitals have all of the resources they need in order to provide this care. So do they have sufficient access to supplies, like personal protective equipment? Do they have enough ventilators? We need to know whether and where shortages are occurring. So if our case numbers are outpacing supplies, that's just one of the things we have to ask. But also, it's useful to know so that we can see if we can possibly reallocate healthcare resources or transfer patients to reduce strain on certain facilities. Not every facility is going to be affected the same way, and not every location is going to be affected the same way all at the same time. So it may be possible, even through enhanced surveillance of the health system, to understand if we can kind of reallocate to ease some of the stresses in some places. And then critically, I think we also need to monitor our healthcare workforce, because we've given a lot of attention to some of the hard stuff, the ventilators and the personal protective equipment, and those are utterly essential. But we need people to wear the PPE, and we need people to power the ventilators. And one of, I think, an important indicator that we should be monitoring is healthcare worker infections and healthcare worker absences, possibly due to exposure-related quarantine. Because if we don't have enough healthcare workers in a health facility, then the capacity is clearly going to be limited there. So I think we need to establish those two surveillance streams. And once we get a sense that we are seeing progress in both of those areas, where we can begin to be a little bit less panicked about how the case numbers are going with respect to kind of the very somewhat fixed limits of the health system, I think that will be the point where we can start to think about perhaps a phased return. However, even if we get to that kind of more, kind of slightly more relaxed point, the work clearly will not be done at that point, right? As soon as we ease up those measures, we may see an increase in cases. So these measures, if they are relaxed, will have to be done incrementally. Some of the measures will probably have to be maintained for quite a long time. It's going to be critical, as long as this virus is still circulating, that we continue to protect those who are most vulnerable to severe illness and disease, so that they don't wind up in intensive care units, right? So the elderly and those with underlying health conditions may have to remain protected for as long as the disease is circulating, or until perhaps we have a vaccine or a specific treatment that could lessen their chances of becoming severely ill and dying. It's crucial that we have a plan and resources for identifying and isolating the COVID-19 cases that occur once we begin to release these measures, because, again, we don't want to have done all of this just to find ourselves back where we started. But right now, I don't feel that we have enough of a plan for finding and isolating cases and conducting contact investigations, we're still hobbled by lack of testing and lack of personal protective equipment. And health departments still don't have the tools or person power to do the investigations they need to do. So when people ask me, when will it end? When can we go back to normal? It's not purely a function of the disease and disease transmission, but also about what resources we have to manage it when we've flattened the curve, when we've determined that we've flattened the curve. I think the next phase is also an opportunity. I mean, we don't want to go backwards. We don't want to come out of this and still experience the same vulnerabilities. We need to come out of this with a reimagined health system that's not so susceptible to collapse. You know, prior to the pandemic, I led a team at Johns Hopkins that worked with colleagues at the Nuclear Threat Initiative and the Economist Intelligence Unit to create the first ever Global Health Security Index, which assessed the health security of 195 countries, specifically with respect to their readiness for a pandemic. And what we found was that no country was fully prepared for a pandemic, which we're clearly now witnessing play out across the world. But most worryingly, we found that countries' health systems were their weakest points. And this wasn't surprising to us because, you know, we'd watched recent events like Ebola in the Democratic Republic of Congo and clearly saw evidence where an unprepared health system could then become a focal point of disease transmission to the broader community. But we also found that across the globe, health systems were largely unprepared for pandemics, even in high-income countries. And we're very much seeing this play out today. The fact that we're all sitting home, social distancing, is just we are trying to prevent our health system from collapsing. So I think one of the things we're going to have to start doing as our sort of next phase of work is making sure for real this time we include health systems in our efforts to strengthen countries' health security capacities. And this may sound like an obvious thing to say, but I think it's somewhat lamentable that for the most part, efforts that have been aimed at readying countries' abilities to prevent, detect, and respond to epidemics and pandemics have largely focused almost entirely on public health capacities. Right? We've made great progress in strengthening laboratories and surveillance systems across the world, doing work on risk communication. I mean, clearly more work needs to be done in those areas for sure. But important work, it's very important work, but what has not been included enough in these efforts, I believe, is our health systems. Much of the work that's been done in terms of strengthening health security capacities here and elsewhere, that have focused on these kind of public health capacities, they tend to miss or not include the kind of foundational capacities that exist in health facilities or health systems, right? So if we work to strengthen public health laboratories and to make sure they're capable of doing certain tests, we also need to do work to make sure that there are enough clinicians to collect specimens that the public health lab is hoping to test. These clinicians need to have the supplies to collect these specimens and to do it safely. So we need to come out of this with a better sense of what's needed to equip health facilities to be ready for pandemics and commit to building those capacities. And the kind of chart I'm showing here was from a project that we did that was funded by the Rockefeller Foundation, where we tried to develop a health systems resilience checklist. And as part of that effort, we did an exhaustive literature search, and we spoke to dozens of people who were involved in either response to epidemics or significant outbreaks, or even natural hazard events, as well as folks who were working in the field of health system strengthening. And we tried to identify from all of that, the literature, from firsthand experiences, if a health system were to respond to an infectious disease emergency, what capacities, what capabilities would it need to have? And we kind of created these bins of capabilities, capacities and capabilities. And we then sort of as a thought exercise kind of compared it to a tool that's being used around the world to assess countries' countries' readiness for infectious disease emergencies. There's a tool that's been developed by the used by the World Health Organization. It's called the Joint External Evaluation, and more than 100 countries have signed up to do this. And when they sign up, they get a team of external experts that come into their country and ask them a lot of questions about what they're able to do. It's a very great process. I think it's enormously valuable and a very important exercise for countries to go through, because it's a great strategic planning exercise in particular to help countries think about, were an event to happen, where would they have strengths and where may they have weaknesses. But we compared all of the things that we found were needed in the health system and then looked and see if we could find questions in the JE that related to it. And the large part, the answer was largely no. The JE isn't oriented around health systems, which is not a criticism of the JE itself, but just to say that we need to do a better job of bringing into the work of health security strengthening also people who work on health systems. It was an interesting exercise when we were doing these interviews with experts. We talked to a lot of people who work in the field of health system strengthening, and very few of them had even heard of the JE tool. So I think that to us suggested that we needed to do work to kind of bridge those two communities of practice. I think now that work is being done by itself. I think this COVID-19 situation is very much illustrating our dependence on the health system and why weaknesses in that area make us so vulnerable and really limit our public health response. And so I think going forward, we need to use this opportunity to strengthen our health system such that we don't have to find ourselves stuck at home yet again when another virus emerges. So I'll end there, and I think we'll maybe have some time for questions.
So thank you so much, Dr. Nazo. That was really a terrific presentation, a lot of very practical information that I think we all needed to hear, to think about what data is needed to monitor in order to know if we're ready to, stop the social distancing, and also the next steps for planning to strengthen our healthcare system. I want to start our Q&A with a question that came from the chat, and I want to target this to Dr. Schuchat. So one of the questions is, it appears like, states of California and Washington implemented very early social distancing. And what have we learned from their experience so far? Is there evidence of flattening of the curve? Is there anything that you could say that we can learn? We realize that that's early experience, but we're just wondering what you're seeing there.
Yes, thank you for that observation. It's encouraging that the Washington state seems to be flattening, as well as Northern California. But I would say that the outbreaks in those two areas were less generalized at the time that the mitigation efforts began. The Seattle-King County area was hard hit in the long-term care facility, assisted care facility, healthcare environment, and Northern California, sort of a mix of things. The East Coast has had enormous numbers of importations, and so the New York City, it wasn't just a few chains of transmission that needed to be interrupted. There were so many people returning from Europe at the time that Europe really took off that the mitigation started later, basically. So I think the question is correct that early mitigation probably helped, but the New York City area was seeded by quite a bit of virus. And I think a factor that's important in this virus as well as others is the super spreader phenomenon, where clearly in the Evergreen facility or the Life Care facility in Seattle-King County, there was a super spreading event given the vulnerable population and the circumstances there. But spread from one to very many is a problem in a number of other areas where we've seen local spread take off really quickly. So, the cruise ships are famous for that, a meeting in Boston that spawned quite a few cases. And because the virus can be spread when a person feels well before symptoms develop and possibly when they're asymptomatic, there can be a lot of unrecognized transmission before you realize that you have community spread. So earlier mitigation definitely can help. The question of whether it can be sustained anywhere is really the topic of the conversation today. Thank you.
And just a quick follow-up, I hope, Dr. Schuchat. What are you seeing in terms of the types of data collection that that Jennifer was talking about in terms of assessing health system capacity, availability of resources, availability of healthcare workers? Is that something that the CDC is assessing across states and across the country? And also,
yes.
I know surveillance as well is picking up.
Yes, let me make a few comments about those very excellent points. There are a couple different approaches, and one of the challenges in this response is to make sure that we're coordinated and not duplicating efforts, and that there's streamlined data collections to not further burden the healthcare system or the public health sector. So of course there's an attempt to use as many open source data or automated, laboratory reporting rather than manual kinds of reports. But there's something called the National Healthcare Safety Network, or NHSN, which is a system we use for healthcare-associated infections and antimicrobial resistance in about 7,000 acute care hospitals around the country. It has good participation because there have been some Center for Medicare and Medicaid Services incentives associated with reporting through that system. And they have launched a COVID-19 module for that healthcare capacity types of parameters, really trying to get at, ventilators, critical care beds, staffing, and so forth. It was the feeds from that are really directly fed into the National Response Coordination Center that FEMA and the CDC and the Assistant Secretary for Preparedness and Response are all staffing to help really with some of these allocations of scarce resources, ventilators or personal protective equipment. So that is one of the systems that's been stood up. There's some other data collections that are also going on. Certainly the issue of getting beyond laboratory test results or hospitalized patients is going to be very important for us to understand the full spectrum of the disease, but more importantly, the full burden of just how much disease has occurred. And to get at some of those measures like hospitalizations requiring intensive care units, we are using an expanded version of our Emerging Infection Program Network, or FluNet, which looks at flu hospitalizations in 14 states in a defined population that can get at the severity and really that utilization of the scarce critical care beds, as well as risk factors for those complications. There's also a lot of discussion about serologic surveys, trying to help us understand just how many people are infected after a wave goes through one of these communities. That can be important for us to understand who is still susceptible and maybe at risk for a subsequent wave if we release or when we release the mitigation steps. Also important because you have this paradox that the more effective your mitigation efforts, the less people that will be infected and potentially asymptomatically infected, and the more susceptible the population remains to further exposures and disease when you reopen. So those are a few of the data streams that are in progress or ongoing that we hope will help us get a picture of both where we are right now across the country and where we're going as we try to get away from looking at having to do very, very difficult mitigation until a vaccine is available. That's pretty much unfathomable. So we're trying to get as much understanding of is that healthcare system able to take on a resurgence if it occurs? Is that public health system capable of doing aggressive case identification, contact tracing, and isolation if you really suppress the virus? Do we have the testing capacity that can help us rapidly identify cases in order to isolate them? Those are the types of data streams that we're gathering now as we look at this continued extensive mitigation in the month of April.
Mm-hmm. Thank you so much. A question now for Dr. Galea. Could you speak to the anticipated short and long-term impact on children and youth in terms of mental health issues, and are there things that can be done now to try to mitigate those?
Yeah, it's an excellent question. The children and youth are as susceptible to mental health symptoms as our adults, and everything I said applies to children as they do to adults. In many respects, children are more susceptible, and the current thinking, I think, is that most mental disorders are rooted in childhood and adolescence. In a book I did it about 10 years ago with several colleagues, we talked about the life course approach to mental disorders, and the majority of mental disorders really start in childhood and adolescence. The problem with mental disorders starting then is that they end up having implications throughout the life course. We know that people who have mental disorders that start in childhood or adolescence will then go on to have a trajectory that's longer, more severe, and where the mental illness will intersect more with physical health and with social and economic functioning. In terms of what can be done, the approaches are exactly what I outlined earlier broadly for children and for adults. It would be education, it would be screening, it would be making sure that care is available, and it would be making sure that the economic conditions and social conditions faced by their parents are dealt with. Some studies have shown very clearly, for example, that children of mothers who have depression or mothers who have anxiety symptoms, general anxiety or post-traumatic stress, those children are much more likely to have delayed social and economic, social and developmental milestones than children of mothers who are not depressed or who don't have anxiety symptoms. So unfortunately, the implications of this for children are serious. And to my mind, the more we can do to mitigate these consequences, both for children and for their parents, because that again affects the trajectory of the mental illness in children, it will yield enormous dividends for us as a society in terms of return on investment if we can invest now in mitigating these consequences.
Dr. Galea, is there any evidence that sort of more broad-scale population-based interventions might help? One of our people online on the chat asked about, mindfulness or other kinds of maybe broad-based interventions that could be done at the population level, or alternatively in low-resourced areas. Could we consider the use of healthcare workers who are lay people that are trained, for instance?
So there's a literature on universal versus targeted interventions, and things like mindfulness are very difficult to deliver to millions of people. They work much more in targeted ways. But probably my read is that it is a combination of universal approaches and targeted approaches to higher risk populations that probably will have the greatest yield. So I think it's entirely reasonable to say at the population level, we're going to aim for education about mental health, screening for mental health, so that we can then direct people who need it to more intensive therapeutic approaches, and think of mitigating social and economic stressors as a form of treatment for mental illness. That's at the population level. Then to say for higher risk populations, which in particular cases may be children, maybe those who are affected by COVID or by its economic consequences, for those groups, let us train potentially lay workers or lower skilled medical workers to deliver higher intensity approaches that can prevent or mitigate mental illness to higher risk groups. And I think it's that kind of combination that we need to embrace collectively to minimize or reduce the mental health consequences of this event and the consequences of its consequences.
Very good. One question, thank you, and now this is for Dr. Karlawish, that's been posted actually by several people on the chat, is that, Jason, you talked about the risks in terms of the risks of the physical distancing itself, but many have asked about, people who are more vulnerable to the infection itself, such as disabled populations, some ethnic minority groups are found to have higher rates. In African Americans, for instance, the LGBTQ population, homeless population, possibility in pregnant women. And so could you speak to that for just a minute and separating that group from the other groups that you discussed?
Sure. Two thoughts come to mind. When the science shows us that certain types of individuals are at greater risk of getting infection, then the next step is to say, well, what's being done to particularly reduce their risk? That's just sensible. The second point that comes to mind is I think the group that presents the particular dilemma are those who are at greater risk of getting the disease, but also need physical contact to live because, for example, they have a chronic illness that requires contact with other individuals, they're disabled, they have cognitive impairment and require a caregiver, they live in a congregate setting. All the groups I outlined there and more. That's where we face this dilemma of how can we continue to provide care for them that maintains their well-being and quality of life, and at the same time reduce the risk of developing the infection. And as has been pointed out by several speakers, if we were doing social and physical distancing for just a week, we could tolerate that. But if this endures for weeks and months, we're going to have harms to those individuals. And so we have to begin to think about ways to both keep them from developing the disease, and in many cases also therefore spreading it, but also being able to continue to take care of them. And so again, I'll repeat, but I do think that we have to think more aggressively about providing resources to nursing homes and other types of congregate settings where people just simply can't leave and go elsewhere, both for their well-being and also to minimize continued spread.
Right. And that's going to be a high-risk population, as Dr. Nuzzo indicated, for a long time to come. So we've run out of time for questions right now, and so I just want to offer a quick closing that, we've learned so much today from our incredible panelists. There's a steady increase, as we're seeing, in cases in the U.S. and some preliminary evidence that physical distancing is working. Individuals are taking on hardship for the greater public good, which is very inspiring. But we've also learned about the substantial risk to physical distancing, including social, economic, health, and mental health risks that pose tremendous challenges to the livelihoods and health of many vulnerable populations. And we've heard about ways that we can begin to mitigate these risks. And these are important challenges and areas that we'll need to take on together as a community and as a nation. And we've heard some very helpful information on how to guide the decision about when and how physical distancing should end, how we're going to go about it in a stepped way, and about appropriate next steps. I know there's still a lot of uncertainty and we have a long way to go. Our overarching goal here through the National Academy of Medicine, the American Public Health Association, and through the efforts of many, many groups in the CDC is our dear hope that we will learn from this. We will recover and will emerge stronger, more unified, more resilient, and prepared to face future crises with a stronger healthcare and public health system in place. And I really think this is our opportunity to learn. You've heard so much about what we need to know, what we need to learn, what we need to get stronger. And working together, I really believe we can make this happen. So that concludes today's webinar. And our next webinar will take place the week of April 6th. And it's going to address emerging evidence on COVID-19 spread and treatment. And so really topics that are on everyone's minds. Everyone who registered for today's webinar will receive an invitation automatically to the next webinar. And this webinar has been recorded, and the recording, a transcript, and all the slides will be available on the website here on the slide, covid19conversations.org. So follow these webinars and please spread the word. They are intended to provide authoritative and evidence-based information for you. I want to close by thanking our terrific panelists. Thank you so much for being here. Thanking the APHA and the NAM for sponsoring this webinar series. Thank you to Victor and Georges, to our co-chairs, Nikki and Carlos, and to our advisory board for your amazing leadership. And a special thank you to Susan, Laura, and Jenna from APHA and NAM who made this webinar possible. And our biggest thanks to all of you, our listeners, for joining us today, for sending in your terrific questions, your comments, and your thoughts. And we're sending out, all of us are sending out your best wishes for your health and your safety. Please stay well, stay safe, and stay physically distanced. Thank you so much. Until next time.
And again, that does conclude this webinar. Thank you for your participation.